So this is a 45-year-old gay man who was referred to our local hepatology clinic in May 2010 from his primary care physician because he had gone in for some routine blood tests, and the primary care physician had done liver enzyme testing and had said, "Oh, this gentleman has got abnormal liver tests. Can you please see him in the hepatology clinic?" So just to work out what the abnormal liver tests were, he had an ALT of 112. This is international units per liter. In our laboratory, the upper limit of normal is 40. His AST was 152. Upper limit of normal is 40. Bilirubin was 32 micromoles per liter. So the upper limit of normal in the micromoles per liter in our laboratory is 17. His albumin was 32 grams per deciliter. I think that's the same unit that's used everywhere in the world. So you'll all be familiar with that albumin. And the platelet count was 98. Again, it's cells per times 10 to the power 9 cells per cubic liter. And his prothrombin time was 15 seconds, which was normal. So just so that you've digested these results, what do we need to do in terms of taking a further history? Remember, this is a guy who is being sent to the liver clinic, and I think that's the really important issue here.
So what would you ask this patient?
Does he take drugs?
Yes.
So does he take drugs?
Yeah, absolutely.
And how?
Clearly very important. So Mike, why is that so crucial in this?
One of the concerns you might have is that he's caught either hepatitis B sexually, and of course you'd then want to know what his hep B surface antibody status was, or core antibody status, and he may have contracted hep C because there's lots of nasty hep C going around. I think the other thing, of course, is that you don't yet know whether he's HIV positive or not.
Yeah, so, really, top of your list of differential diagnoses here is, viral hepatitis, chronic viral hepatitis infection. And big question here is there underlying HIV infection? And so the reason I brought this bit up here is how many of your primary care physicians or your hepatologists test for HIV in patients that are suspected of having a viral hepatitis infection?
It's obvious you must take HIV test first, and the hepatitis B or C.
Yeah, it's clearly very important. I mean, in the UK, we think that 30% of our HIV remains undiagnosed because we don't think enough about HIV testing. So let's continue with the case. So actually, a very, very, very good history was taken from this patient by our hepatology team. So he, as a single partner for over 20 years, denied other risks when asked, but had been treated for syphilis 10 years ago, drinks very little alcohol, denied any recreational drug use, but this wasn't asked specifically in terms of drugs, but said, do you use any recreational drugs? No, I don't, sir. No previous HIV test ever, and no previous viral hepatitis tests ever. No medication or significant other medical history. And no family history of liver disease. So this is the sort of history that you need to get in terms of looking at people with liver disease. He was examined, he was thin, had bilateral small cervical lymph nodes, oropharyngeal candidiasis, so this was starting to ring alarm bells already. He had pulmonary erythema and multiple spider nevi, 1 centimeter palpable liver, but no splenomegaly, no ascites, no ankle edema. And he went on to have a number of tests performed. Very fortunately, he did have an HIV test, and he was HIV-1 positive with a CD4 count of 120 at 19%, viral load of 87,000 copies per ml. Hepatitis C IgG was positive, his RNA was positive at 1.2 million international units per ml, and he has got genotype 1b hepatitis C. His hepatitis B S antigen negative, anti-core positive, anti-E positive, but anti-S negative, hepatitis A total antibody positive, syphilis clearly IgG positive, toxoplasma IgG positive, cryptococcal antigen negative, and he even went on to have an ultrasound scan which showed a liver with an irregular edge, dampened hepatic venous signal, and a spleen of 13 centimeters. Okay, so this is, all the baseline tests that this guy had, and then, a knee-jerk referral to the HIV hepatitis co-infection service. You need to manage this guy. Okay, so just hang on to those results for a second, because now I'm going to ask you a multiple choice question. You have one answer to pick from. What other investigation do you want to do? Do you want to do a liver biopsy to stage his liver disease? Do you want a fibroscan to stage his liver disease? Do you want to do an upper GI endoscopy to assess for varices? Do you want to do more blood tests to look for other causes of liver disease? Or no, we have enough information to be able to make a treatment decision?
So there is only one answer.
One correct option.
One correct option.
I think what we're trying to point out here for all of you is that there's enough in this man's clinical examination and his blood test to suggest that he's got advanced liver disease. So just so that you're aware, the first thing to look at is his liver enzymes. If you see a reversal of AST to ALT ratios, yes, that's a very, very good clue that this patient has got advanced liver disease, i.e. cirrhosis, unless he's got alcoholic hepatitis or NASH or something else. But in the context of viral hepatitis, as soon as you start to see the ratio of AST to ALT reverse, then that should get alarm bells ringing, especially if you see it with a low platelet count and a borderline low albumin. That really does suggest that this patient has got advanced liver disease. The other thing that makes a suggestion that he's got advanced liver disease is that he's got stigmata of end-stage liver disease, i.e. pulmonary erythema, spider nevi. So all of these are enough to make the diagnosis of advanced liver disease, and you really don't need to put this patient through a liver biopsy, and perhaps you don't need to stoop to sending him to the hepatologist for a fibroscan. What is really, really important is that we need to monitor for complications of end-stage liver disease. The thing that is really very important for this patient, what's going to kill him if not managed properly, is esophageal varices, one of the complications of portal hypertension. And this is an algorithm. You don't need to look at this in great big detail, but this is the algorithm that hepatologists use for managing esophageal varices in patients with end-stage liver disease. So, whether they have varices that are small or big, and whether there are Child-Pugh classification on cirrhosis is, and whether you need to use non-selective beta blockers or not. And this is very, very important. It is also very important to be able to prognosticate for this patient in terms of their end-stage liver disease. There are a couple of scoring systems that one can use to prognosticate. There is the Child-Pugh scoring system, which is slightly old and slightly imprecise in that it doesn't really prognosticate in terms of morbidity and mortality, but it is very good for classifying patients in terms of natural history studies. So this is Child-Pugh scores are classified as A, B, or C, and these are the factors that one uses in order to give people those scores. Don't worry about the details of this, just be aware that a Child-Pugh score is available, and that becomes very important. Perhaps what's very important in terms of predicting morbidity and mortality from end-stage liver disease is this score called the MELD score, which is a very complex equation. It's available on the internet at the Mayo Clinic website, but it involves a number of things: bilirubin, prothrombin time, renal function, and then etiology of the end-stage liver disease. And there's clearly some data to suggest that the higher your MELD score, the higher your mortality rate in the time following the assessment of MELD. And in fact, in liver transplant assessment now, MELD scores are used to prioritize people in terms of who needs a transplantation sooner rather than later. Okay, so let's go back to this patient. So he did have an upper GI endoscopy, and there was no esophageal varices. There was just some portal hypertensive gastropathy. So, you know, we were sure this man was going to have a little bit of portal hypertension, but he was very lucky there was no varices. So I suppose the next really easy question is, treat his HIV or treat his hepatitis C. He's got a CD4 count of 120, viral load of 120,000. Okay, so we opt to start this man on antiretroviral therapy. We kind of decided that antiretroviral therapy first, get his HIV well controlled, and then we'll treat him or consider hepatitis C treatment. So there were two questions I was going to ask. Are there any drugs we should avoid in people with advanced liver disease? And are there any drug in combinations that are thought to be better for advanced liver disease than others? And so I put up a list of drugs here with loads of question marks, loads of issues, but these are the sorts of things that one needs to think about. So clearly, nevarapine is associated with risk of hepatotoxicity. The risk of hepatotoxicity, I don't think is any higher in people with advanced liver disease than those without advanced liver disease. But if you do get hepatotoxicity from nevarapine, then your risk of decompensation is very high in people who've got advanced fibrosis. Clearly, DDI is don't do it, is what DDI stands for. And so clearly we shouldn't be using DDI in the context of hepatitis C HIV co-infection. I don't think we should be using DDI for anybody, to be perfectly honest. We know that ritonavir is associated with increased risk of hepatotoxicity. It's primarily driven by the higher dose of ritonavir that we use with ritonavir, and I don't think anybody ever uses ritonavir. Right? Unfortunately, there are still HIV access programs that continue to use D4T. So I was in Vietnam recently, and they still use D4T as their first-line nuke backbone.
Low dose.
Low
D4T.
dose. Absolutely. Now, I've put darunavir up there as a provocative discussion because there was some early data to suggest that darunavir was associated with hepatotoxicity in specific subgroups of patients, and there were a number of reported deaths with darunavir in the early registration studies. These were only a handful of patients. I do have to say that the vast majority of these were hepatitis B HIV co-infected patients, and we don't know what the mechanism of this was. We think this is probably immune restitution flares rather than toxicity of darunavir, but that's something to bring into the discussion. I think the drug that's causing a lot of interest at the moment is maraviroc, and whether maraviroc has an anti-fibrotic effect within the liver or not. There are certainly data being generated regarding this. I'm not so sure that these data are very strong, but that's something that comes up in discussions every now and again. Okay, so he starts combination antiretroviral therapy. I use one of my favorite regimens, which is Truvada and boosted lopinavir, i.e. Kaletra. He also gets cotrimoxazole for 80 milligrams once a day as primary PCP prophylaxis. I'm not sure that was really required, but we went for it anyway. And he has a fantastic HIV virological response, and by week 12, actually he's HIV undetectable. CD4 counts are up to 220 at 22%. We followed his liver enzymes very carefully. His ALT is 82, ST 90. Platelets have gone up a little bit. Prothrombin time remains normal, and in fact his albumin is climbing. So we're doing very well with this man. So my next question now to you is, what other monitoring does he need? So should we do 6 monthly fibroscans? Should we send him to the hepatologist to try and get the fibroscan in clinic? Shall we do 3 to 4 monthly HCV RNA levels? Shall we do annual upper GI endoscopies? Shall we do 6 monthly ultrasound scans and alpha fetoproteins? Shall we do all of the above, or we don't really know? So I think it's really important, and one of the key issues for people with cirrhosis and hepatitis C is hepatocellular carcinoma surveillance. Hepatocellular carcinoma, in the context of HIV and hepatitis C co-infected patients particularly, is becoming very important as a cause of morbidity and mortality in our group of patients. We really need to monitor for this. So these are the American recommendations for, they've now been adopted by ASLD, recommendation for surveillance of hepatocellular carcinoma, and certainly hepatitis C cirrhotic patients patients. The patient should be screened 6 to 12 monthly, some say 3 to 4 monthly. It's what you can afford to do, but as a minimum, at least twice a year, and if not that, at least once a year. Alpha-fetoprotein alone should not be used for screening unless an ultrasound scan is not available. Alpha-fetoproteins are not very sensitive and very specific. The surveillance interval does not need to be any shorter than 4 months, even in those people at the highest risk of hepatocellular carcinoma. So these are the guidelines, and just so that you're aware. Certainly at the Royal Free, we would do 6 monthly ultrasound scans on patients with cirrhosis, either with hepatitis B, hepatitis C, or non-viral hepatitis cirrhosis. For hepatitis B patients who are well controlled on tenofovir-based antiviral regimens, we would screen once a year rather than twice a year, because we can't afford to do any more than that, and our radiology department is not up to it. Okay, so 6 months post-antiretroviral therapy, his CD4 count's now reasonable. It's 280 at 24%. So even by the Romanian national guidelines, he would be ready for anti-hepatitis C treatment. His liver's stabilized out, and we now ask the question, is it time to tackle the hepatitis C? So what are the issues when you want to treat patients with what we think is advanced fibrosis with pegylated interferon ribavirin? What sorts of things do we need to think about?
And I just ask, he's had a partner for 20 years. A, did the partner get an HIV test? B, were they having sex? C, is the partner HIV or hepatitis C positive? D, are they still having sex? And E, is he now, knowing that he's HIV positive and feeling rather better after doubling his CD4 count, out on the town having sex with anybody else? Because I think the public health side of it also is part of an issue.
Okay, so let's answer those questions backwards. HIV is very well controlled, but he's not feeling better because he's hepatitis C infected, in fact feeling very fatigued and hardly able to go out to a club, let alone go and have sex. His partner is HIV, Hep B, Hep C negative, and they are having sex, which is protected as sex only now. But clearly important. I'm sorry I didn't kind of go into that, but those are all the things that needed to be tackled right at the beginning of all the treatment decision making. Okay, there are some other issues about tackling the hepatitis C, and I just wanted to bring these up for you. So one of the predictors of response to PEG interferon ribavirin is the level of fibrosis. But there's loads of data sets, and I only brought this data set up. This is Rafael Bruno's work from Italy, looking at SVRs with PEG interferon and weight-based ribavirin based on your ESHAC scores. ESHAC scores are very similar to Metavir scores, except that it's 5 and 6 that are kind of really advanced fibrosis. And as you can see, as you get down to being cirrhotic, which is ESHAC 6, your likelihood of response to PEG interferon ribavirin is less than 10%. And so this is a really important consideration. So people need to be aware that the more advanced fibrosis you have, the less likely you are to respond to PEG interferon ribavirin. I'm not sure why that's the case, why advanced fibrosis or cirrhosis affects your response to PEG interferon ribavirin if everything else is equal. My feeling is that it's a blood supply to the hepatocytes that's disrupted by being fibrotic, so you don't get enough drugs into the hepatocytes because of the fibrosis and collagen deposition. There's another little thing that we need to bring into this, in that patients who are cirrhotic when given PEG interferon ribavirin are at risk of hepatic decompensation. We saw this from the early days of the apricot study, where there were in fact deaths associated with hepatic decompensation in those patients that had very advanced liver fibrosis who got PEG interferon ribavirin. Stefan Maas did a very nice kind of analysis based on a very small number of patients, and the thing that's dropped off from the bottom here is the use of DDI was probably the most important factor in terms of risk of decompensation in cirrhotic patients, but other things play an important role too. And so the risk of decompensation is not zero even if you don't use DDI. So please be aware that patients with advanced liver disease are at risk of hepatic decompensation with PEG interferon ribavirin. What about the newer drugs? And I'm going to finish in a minute. This is a realized study, which is a telaprevir study in mono-infected patients. I don't want you to take any of that away, just to take away the pooled analysis, as Karine was saying, that even with the new therapies, if patients are cirrhotic or have got advanced fibrosis, they tend to respond less well than patients who've got lower stages of liver disease. I think the thing that worries us much more than that in patients with advanced liver disease and fibrosis is the risk of serious adverse events. This is the QPIC. I don't know if you call it the study. It's the French expanded access program for telaprevir and boceprevir, really, isn't it, in mono-infected patients. And I think there are something like 450, nearly 500 patients on the QPIC program who are either previous partial responders or relapses to PEG interferon ribavirin who've been given telaprevir and boceprevir in combination with PEG and riba. And then you can see that serious adverse events are almost up to 50% in patients in this group of patients, and that there is the risk of hepatic decompensation and death remains. And if I can remember correctly, Karine and Patrick can correct me, that the risk of death or the cause of death tended to be sepsis or infection events rather than anything else. So we need, even with the triple therapies, we need to be careful. Although having said that, the early virological responses from the QPIC study, certainly out to week 12 in smallish numbers of patients that have made it so far, both on an intention to treat and an on-treatment analysis, looks like they're doing reasonably well in terms of virological responses. Okay, I think that's the end of that case. What did I do with him? He got PEG interferon ribavirin and responded very well, but I didn't show you that. He cleared virus with PEG and riba.